So, if I asked you right now to name the most common eating disorder in the United States,
Yeah.
What would you guess? You would probably jump straight to anorexia
Yeah.
or
Yeah.
bulimia.
Right, because that's what everyone assumes. It's what we're taught to look for.
Exactly. The media has essentially trained us to look for those highly visible, very dramatic physical signs. But honestly, you would be wrong.
Yeah, completely wrong, actually.
Because there is a condition that is, believe it or not, more prevalent than anorexia and bulimia combined. We are looking at a lifetime prevalence of about 2.8% of all U.S. adults.
Which is millions of people.
Literally millions. Millions of people walking around with a condition that society and, honestly, often the patients themselves just completely misunderstand.
Well, and it's because we are so conditioned to look for the loudest, right? The most physically apparent manifestations of a disorder. So the most widespread condition just easily slips completely under the radar.
It's invisible.
Exactly. People are suffering in absolute silence because they don't even realize their struggle has a clinical name.
Which brings us to today's deep dive. We are looking at a stack of clinical materials and service details from Coping and Healing Counseling, or CHC.
Right. A really fascinating telehealth practice.
Yeah, and our mission for you today is to completely deconstruct this highly misunderstood condition, which is binge eating disorder, or BED. And we want to explore how new, highly accessible telehealth models are just fundamentally changing the way patients are finding relief.
It's a massive shift in how we handle care.
Okay, let's unpack this, because despite how incredibly common BED is, we rarely talk about it with the clinical accuracy it deserves.
Oh, absolutely not. We usually just make jokes about it.
Right. We talk around it, we completely misuse the terminology, and we leave the actual struggle in the dark.
So our objective today is to really separate the medical fact from the cultural fiction here.
Yeah.
We want to give you a comprehensive view of both the strict science of binge eating disorder and the modern practical solutions that are actively healing people right now.
Because we have real solutions.
We do. And when a condition affects nearly 3% of adults, I mean, that is a public health reality. It demands precision, not just, passing conversation.
No, I totally agree. And if this is affecting more people than anorexia and bulimia combined, it naturally begs the question of why it remains so invisible, right?
Right.
And going through these sources, the answer seems to lie in this massive gap between how the medical community defines binge eating disorder and how our casual society just completely misuses the term.
Yeah, the word binge has been entirely co-opted by pop culture at this point.
Oh, 100%.
By turning it into a casual verb, we've just stripped it of its clinical weight entirely.
Yeah, we joke that we, binged a TV show over the weekend, or we say we binged on Thanksgiving dinner.
Exactly.
And the context there is always this temporary fun indulgence. But when you read the actual clinical criteria for BED in these source documents, the reality is, it's the exact opposite of a fun indulgence.
Let's break down those strict clinical criteria, actually, just to anchor the reality of the disorder for a second.
Yeah, let's do that.
Clinically, BED requires recurrent episodes of eating what is defined as an objectively large amount of food within a discrete period of time.
Okay, so volume and time.
Right, but volume is only the surface metric here. The fundamental defining characteristic that absolutely must be present is a profound sense of loss of control during that episode.
A loss of control. See, that feels like the crucial distinction here.
It is the core of it.
It's not someone just deciding to have a second helping of dessert because it tastes good.
Yeah.
It is an active, terrifying inability to stop.
Yes, exactly. And the clinical criteria also impose a strict time frame. So to be diagnosed with BED, these episodes must happen at least weekly for 3 or more months.
Wow. Okay, so 3 months.
Right. This isn't about having one bad day, or overeating at a holiday party. It is a chronic, cyclical pattern of behavior that completely hijacks a patient's daily life.
And the sources outline the specific features that accompany these episodes. And honestly, reading through them is genuinely heartbreaking.
It really is.
It goes so far beyond simply eating a lot of food. It dictates the how and the why.
Yeah, the hallmark features of BED are highly specific. The clinical materials note that an episode often involves eating much faster than normal.
Okay.
It involves eating until the person is uncomfortably full and, not just satiated, but to the point of acute physical discomfort.
Like it physically hurts.
Yes. And crucially, it involves eating when not physically hungry at all. The drive to eat becomes entirely disconnected from the body's biological need for fuel.
And the environment where this happens is also a defining factor, right? because the sources specify that this behavior is almost always hidden.
That's right.
People are eating alone because of a deep, profound shame. And then the episode is immediately followed by intense feelings of disgust or depression or guilt.
That cycle of shame is literally the engine of the disorder.
How so?
Well, the guilt fuels the emotional distress, right? And then the eating is a maladaptive mechanism to cope with that distress.
Which then creates more guilt.
Exactly. It's a closed loop. And there is one more critical medical distinction we have to make here, which the sources highlight as the primary differentiator from bulimia.
Okay, what's that?
Binge eating disorder occurs without the compensatory purging behaviors.
Meaning no vomiting, no excessive exercise to quote-unquote make up for the binge.
Right. In bulimia, a binge is typically followed by a compensatory action, like misusing laxatives or vomiting to try and undo the caloric intake.
Right.
In BED, that compensatory action is absent. And because there is no purging, the dramatic physical markers that society typically associates with eating disorders often just aren't there.
So the disorder remains completely invisible.
Trapped entirely inside the patient's internal experience.
Which perfectly explains why it flies under the radar. I mean, people look at someone struggling with BED and they just assume it's a weight issue or, a lack of discipline.
The discipline myth is so pervasive.
Right. We hear this terrible societal misconception all the time, framing it as a willpower problem. But clinically, treating this like a lack of willpower is like telling someone with asthma to just breathe better.
That's a great analogy, actually.
Thanks. I mean, it's true. You cannot willpower your way out of a clinical loss of control wrapped in profound shame.
You really can't. And when we reframe binge eating disorder as a legitimate clinical condition driven by a loss of control, we immediately shift the conversation from personal failing to medical treatment.
Right.
And what's fascinating here is that the medical and psychological communities have developed highly effective, evidence-based treatments that actually address the underlying mechanisms of that loss of control.
Yeah, because if we accept that this isn't a willpower issue, then the traditional casual advice of, just go on a diet is not only useless, it is actively harmful.
Very harmful. A restrictive diet just creates more psychological pressure.
Exactly. So how is the medical community actually rewiring this shame cycle?
The sources list some specific therapies, right? There's enhanced CBT, or CBTE, interpersonal therapy, which is IPT, and DBT, BED.
Yes, those are the big three.
But wait, I have to push back here for a second. You just said that BED involves a physical, almost biological loss of control. Can sitting on a couch talking about your feelings really stop an intense physical urge to eat?
See, that is the common skepticism surrounding talk therapy, right?
Yeah.
But these modalities are not just, talking about your feelings.
Okay, then what are they doing?
They are highly targeted cognitive interventions designed to actually rewire the brain's pathways.
Oh, wow.
Take enhanced cognitive behavioral therapy, or CBTE. It focuses directly on the thoughts and behaviors maintaining the eating disorder.
So practically, what does that look like?
Well, in a practical sense, CBTE helps a patient map out the exact sequence of events that leads to a binge. They identify the subtle emotional antecedent.
Like a specific type of stress at work, maybe? Exactly. And then they actively rewire the brain's automatic response to that specific trigger. They are basically building a wedge between the stimulus and the physical urge.
So they are essentially slowing down the reaction time, so the logical brain can step in before the loss of control takes over.
Perfectly said, yes. And then interpersonal therapy, or IPT, approaches it from a slightly different angle.
Okay.
It operates on the premise that binge eating is often a response to negative moods caused by interpersonal problems.
Interesting.
Yeah, so IPT doesn't focus on the food at all. It focuses entirely on solving the relationship conflicts or life transitions that are generating the emotional distress in the first place.
Oh, I see. So if you resolve the conflict, you essentially remove the trigger for the binge.
Exactly. And then you have DBT-BD, which is dialectical behavior therapy specifically adapted for binge eating disorder.
What does that do?
This one equips patients with vital emotional regulation and distress tolerance skills.
Okay, so if the binging is a maladaptive way to cope with distress, DBT gives them a new functional set of tools to handle that exact same distress.
Exactly. You are treating the root cause of the emotional dysregulation, not just the symptom of the eating.
That makes total sense.
But the sources also introduce a vital medical component that pairs with this psychotherapy.
Right, the medication side of things.
Yes. Alongside these psychotherapies, there is lisdexamfetamine, commonly known as Vyvanse. And the documents clearly state that this is the only FDA-approved medication specifically for binge eating disorder.
See, I have to admit I'm confused by that one. Vyvanse is widely known as an ADHD medication, right?
It is, yeah.
It's a stimulant. How does an ADHD stimulant actually treat an eating disorder? Does it just, like, suppress a person's appetite?
It is a really common misconception that it's just an appetite suppressant.
Oh, it's not?
No, Vyvanse works directly on the dopamine systems in the brain. BED is deeply, deeply tied to dopamine-seeking behavior.
Okay, explain that a bit more.
So, the brain learns that an influx of highly palatable food triggers a massive reward response, right? A huge hit of dopamine.
Right, sugar, carbs, all of that.
Exactly. And over time, the brain starts demanding that hit to regulate mood. By stabilizing dopamine levels in the brain, Vyvanse reduces that frantic neurochemical urge to seek out a reward through food.
Wow.
It quiets the biological noise, basically, giving therapies like CBTE the necessary room to actually work.
Okay, so you stabilize the neurochemistry with the medication, which allows the patient to actually focus on rewiring their behavioral triggers in therapy.
Precisely.
That makes a lot of sense. And it also highlights why the sources stress the absolute necessity of coordinated care. Like you can't just tackle this in a silo.
No, a single therapist working in isolation is often just not enough to dismantle a complex disorder like BED.
So what does the ideal team look like?
Effective treatment requires a three-legged stool, basically. You need a medical prescriber to manage medications like Vyvanse and monitor physical health.
Okay, that's one leg.
Then you need a specialized therapist delivering modalities like CBTE or DBT. And finally, a dietitian who can help the patient rebuild a healthy, functional relationship with food outside of that binge-restrict cycle.
Man, that sounds incredibly comprehensive. But it brings us to a massive, real-world logistical wall, doesn't it?
The access problem.
Yeah. We've established that BED requires this highly specialized, multi-pronged care team. But we've also established that the core symptoms of this disorder are intense shame, hiding, and eating alone.
Right.
So if a disease makes you want to hide, how on earth do you get someone to walk into a brightly lit clinic, sit in a public waiting room, and coordinate appointments with 3 different medical professionals?
The friction of simply getting to the physical appointment is often an insurmountable hurdle for someone battling a shame-based condition.
I can imagine.
Traditional healthcare models literally force a person whose main symptom is hiding to step out onto a brightly lit stage.
It's counterintuitive to the disorder itself.
Exactly. And this is where the telehealth model provided by Coping and Healing Counseling, or CHC, becomes a critical mechanism for actual healing.
Yeah, because if a patient's primary defense mechanism is to isolate in their own private environment, telehealth meets them exactly in that environment.
Right.
Traditional therapy forces them out of their hiding spot, but telehealth basically brings the doctor into the hiding spot.
That's a great way to look at it. By removing the physical exposure of the waiting room, you eliminate the initial spike of anxiety that causes so many patients to cancel their appointments.
Because nobody is watching them.
Exactly. CHC's model is entirely HIPAA compliant, meaning the patient can receive this highly specialized care in the absolute privacy and safety of their own home.
That is huge.
You are fundamentally lowering the barrier to entry for someone whose disorder actively tells them to avoid being perceived by others.
And the scale of what CHC is doing is incredibly impressive when you look at the logistics in these sources.
It really is.
According to the documents, they aren't just serving a single affluent suburb. They serve all 159 counties in the state of Georgia.
All 159.
That geographical footprint is vital. I mean, if you are in a rural county, essentially a healthcare desert, where there are 0 eating disorder specialists, let alone a coordinated team of dietitians and prescribers.
Right. You'd usually be out of luck.
Exactly. But with this, you suddenly have access to the exact same level of specialized care as someone living in a major metropolitan hub like Atlanta.
And they have built a robust infrastructure to support that footprint, too. The sources note they have over 15 licensed therapists, including licensed clinical social workers, licensed parental counselors, and licensed marriage and family therapists.
Wow, that's a big team.
It is. And importantly, the materials highlight that this is a diverse, culturally competent team.
Which matters deeply, especially when we're talking about food and eating habits.
Oh, incredibly so.
Because food is deeply cultural. It is tied to family gatherings, to tradition, to how we express love and identity.
Exactly.
A therapist needs to understand what, like, a Sunday dinner means in a specific culture if they're going to successfully help a patient disentangle a binge eating episode from a really cherished family tradition.
That is such a crucial point. Cultural competence in therapy directly impacts the efficacy of the treatment.
Because of trust.
Trust and just communication.
Yeah.
A patient won't open up about their eating behaviors if they feel they have to first, translate their cultural background to their therapist.
Right, so that's just adding another barrier.
Exactly. And CHC's scoop of practice also reflects an understanding of how complex these underlying issues are. They recognize that eating disorders just don't exist in a vacuum.
Yeah.
They offer individual therapy, couples therapy, family therapy, and teen therapy for ages 13 and up.
And treating someone at age 13 is critical for early intervention, right? Like
Yeah.
intercepting these behavioral pathways before they become cemented for decades.
Oh, definitely. The earlier, the better. And when you look at their broader list of specialties, you see the web of conditions that so often surround and exacerbate binge eating disorder.
Like what?
Well, they specialize in treating anxiety, depression, trauma, and PTSD, grief, and relationship stress.
See, it's all completely intertwined. If the BED is essentially a coping mechanism for emotional distress, you need a clinical team that can actually identify and treat the underlying trauma, right?
Right.
Or the unprocessed grief or the severe anxiety that is secretly fueling the fire.
You have to treat the whole person.
But, having access to this incredible specialized care doesn't mean anything if the patient can't afford it.
That is always the catch, isn't it?
It is. Traditional eating disorder treatment is notoriously expensive, often requiring out-of-pocket payments that can run into the hundreds of dollars per hour.
Financial friction is honestly just as preventative as geographical friction.
Yeah.
A patient might finally have the courage to seek help, only to be turned away by the cost of the initial intake session.
But CHC actually accepts major commercial insurance and Medicaid.
Which is pretty rare for specialists.
Extremely rare. And for Medicaid patients, the materials state there is a $0 copay.
Wow.
Right. And the cost per session for major commercial insurances ranges from $0 to $40.
That is amazing.
Finding highly specialized eating disorder therapy and a coordinated care team for under $40 a session, all from the privacy of your own home, it completely flips the script on who gets to heal.
It democratizes it.
It really changes eating disorder treatment from a luxury for the wealthy to an accessible right for the general population.
It is the definition of radical accessibility. They have taken a complex, highly stigmatized condition that requires coordinated care, and they have systematically dismantled the geographical, the logistical, and the financial barriers that traditionally prevent people from ever making that first phone call.
To bring all of this together for you listening, we started today by looking at a condition that society has vastly misunderstood.
Right.
We've learned that binge eating disorder is the most common eating disorder in the U.S., affecting millions of adults who very often suffer in complete silence.
Because of the shame.
Yes. We've learned that it is a serious clinical condition defined by a terrifying biological and psychological loss of control. It is not some moral failing or lack of willpower.
Not at all.
And most importantly, we've explored how highly coordinated, evidence-based, care-like cognitive therapies that actually rewire the brain's response to triggers and medications that stabilize the dopamine pathways is now radically accessible through telehealth practices like coping and healing counseling.
The path to healing is no longer theoretical, or hidden behind prohibitive costs. It is an active, available reality right now.
Yeah, so if you or someone you know is caught in that cycle of shame in Georgia and needs this kind of coordinated private care, you do not have to keep it hidden anymore.
You really don't.
You can reach out to CHC directly from your own home. Their phone number is 404-832-0102. You can visit them online at cheattherapy.com, or you can email their clinical team at support@cheattherapy.com. And all of that contact information is provided right there in the sources.
Given that binge eating disorder thrives in isolation and shame, the shift to 100% remote telehealth isn't just a matter of modern convenience.
Right, it's more than that.
Much more. The platform itself acts as a direct countermeasure to the disorder's symptoms.
That's a great point.
And it really makes you wonder, how might the privacy and accessibility of telehealth completely revolutionize our ability to diagnose and heal other highly stigmatized mental health conditions that have traditionally been hidden behind closed doors?